Um, these are my disclosures relevant to this presentation. So the learning objectives for today, I'm going to spend a few slides initially just refreshing your memory about what exactly PML is, and then describe the relative risk of PML associated with autoimmune rheumatic diseases. And then to talk a little more specifically about what we think we know about the role of immunosuppressive therapies in the development of PML in these patients. I'm not going to say too much about Natalizumab, given that you've heard about this yesterday, but I'll mention it in passing just for the purposes of comparison. And at the end, then maybe just to spend a few moments just talking about the outline to the approach to diagnosis and management of PML in patients with autoimmune rheumatic diseases. So PML is progressive multifocal leukoencephalopathy. It's a demyelinating infection of the central nervous system, which is devastating and rapidly fatal in most cases. Most survivors are left with significant neurologic deficits. It's due to reactivation of the JC virus, which most of us in the room have lying dormant in our system. This is a polyomavirus. These are DNA viruses. The best understood are the JC and BK viruses, but there have been a number of other polyomaviruses recently described and implicated increasingly specifically in tumor pathobiology. These viruses are essentially ubiquitous, typically acquired during childhood, although the mode of transmission is not clearly defined as of yet. Once acquired, the virus remains latent and hangs out in the renal epithelial cells and lymphoid tissues. And there's some speculation as to whether it may be latent in other tissues, such as the central nervous system. It may be shed intermittently in the urine and sometimes, less commonly, circulate in the blood in an asymptomatic fashion without causing active infection. And in order for the development of PML, the virus must undergo a conformational change to an infective or pathogenic form, and it then can trigger infection, lytic infection of oligodendrocytes and astrocytes, leading to the clinical presentation of PML. And this primarily occurs in immunosuppressed patients. These are just some representative images. You can see that on the left-hand panel here, this is a T1 weighted image, and you can see this hypo-intense area here. It's typically hyper-intense on T2 and images and flare images. And you can see that the CT scan on the right-hand panel there doesn't really tell you very much, and this is pretty typical. One of the cardinal features is of rapid progression, and this is the interval change over the course of a month in this patient. And this is the typical pathology. This is a myelin stain, and you can see this areas of demyelination here, and it's taken up by macrophages on the close-up view. And then you can see these bizarre astrocytes and lysyl oligodendrocytes. And we can identify the presence of the JC virus by a variety of techniques. However, this performance of a biopsy isn't necessary in most cases where we can identify the presence of the JC virus by PCR in the cerebrospinal fluid. So obviously, most patients with PML have a background of HIV/AIDS, and next on the list would be hematologic malignancy. So historically, it's been underappreciated that chronic inflammatory diseases could result in the development of PML. In terms of prognosis, although a number of agents have been tried and are tried in individual cases, there's no proven specific antiviral treatment. And in non-HIV patients, the outlook is generally very dismal, and with a median survival of just under 3 months, and 80% have succumbed within 9 months. And in HIV patients, at least there is a potentially remediable predisposing factor in the HIV virus itself, and the survival in this setting is significantly improved with the institution of highly active antiretroviral therapy. Although, as you've probably heard during the course of the meeting, the development of immune reconstitution inflammatory syndrome is something to watch out for in that setting. So why is a rheumatologist talking to you about a weird neurologic disease? In terms of the association with rheumatic diseases, historically there were a few case reports, and the assumption was that it was related to immunosuppressive therapy. But more recently, there have been a number of FDA alerts with regard to the use of some of the medications that we commonly use in rheumatology and the development of PML, notably Rituximab and Mycophenolate. And as the understanding of PML has evolved, we now understand that there can be contrast enhancement on MRI scan, there can be inflammatory forms, etc. And so we really need to think about this condition in the differential diagnosis of neurologic manifestations of rheumatic disease, such as neuropsychiatric lupus and cerebral vasculitis. In a recent survey of patients, of rheumatologists rather, with regard to PML, concerns were, it was expressed that concerns regarding PML affect both physician and patient decisions regarding the use of biologic agents, and that rheumatologists have important real and perceived learning gaps regarding PML. So why is this rheumatologist talking to you about a weird neurologic disease? Well, this was an unfortunate case of a 42-year-old female that I saw in the consult service here with Dr. Len Calabrese. And she had a long-standing history of lupus, which really had been very low ball. She had been treated with Plaquenil and the odd little bit of low-dose steroid, less than 10 milligrams per day. And she had presented to an outside institution with subacute neurologic decline and was presumed to have cerebral lupus, treated with steroids and mycophenolate. When she was transferred here to the Cleveland Clinic, then this was presumed to be refractory CNS lupus, and she was commenced on IV cyclophosphamide and pulse-methylprednisolone. You can see her MR images here on the right-hand side with changes compatible with that diagnosis. Somebody clever sent off a JC virus PCR in the CSF, which was positive. It was the neurology team. And then the diagnosis of PML was reached. And so, unfortunately, she died within 3 months of the onset of her symptoms. So this was a very sobering case for us, and I think what was really striking for us was the fact that she had such minimal background immunosuppressive therapy. And this prompted us to look at the literature, and this was up to date through 2009, where we identified all of the cases of confirmed PML where there was a JC virus PCR positivity in the CSF or brain biopsy positivity with a compatible clinical and MR appearance. And of these cases, of all of the cases published in the literature that met those criteria, by the way, none of these patients had HIV or a malignancy. Of all of the cases in the literature, there were 50 in total, and 32 of these had lupus. So this seemed to be very much overrepresented. 2/3 of the cases were in patients with lupus, and then you can see the remainder of the diagnoses there on the screen. And when we looked at the immunosuppressive therapy that these patients had been receiving, it was striking that only 1/3 of the lupus patients and up to 1/2 of the remainder of the patients had ever been treated with an alkylator. And in terms of the immunosuppressive therapy in the 6 months prior to the onset of neurologic symptoms attributable to PML, only 1/6 of the lupus patients and up to 1/3 of the non-lupus patients had been treated with an alkylator. And we can see down here that about 1/3 of the patients in the lupus group, their only treatment had been low-dose prednisone and or an antimalarial, and a handful of patients in each group that had no significant immunosuppressive therapy around the time of development of PML. And this was before the wave of cases with rituximab really came through, so there were only 2 cases treated with rituximab in this report. So I think one of the other unfortunate findings in this study was the fact that a significant proportion of the patients reported had an intensification of their immunosuppressive therapy when they developed the neurologic symptoms, because of the presumption that this was a manifestation of their underlying rheumatic disease, and clearly this was something that would not have aided their chances of recovery. So what can we say from all of this? It would appear that lupus patients would have a unique susceptibility to PML among the rheumatic diseases, which doesn't appear to be proportionate to the degree of iatrogenic immunosuppression. And so clearly host factors play a role also. Clearly those data are subject to reporting bias, and so we did look at this in another way using the nationwide inpatient sample. This was from it's a national hospital discharge database, and we looked at this from 1998 to 2005 inclusive, which encompassed about 300 million discharges. The caveat here is that this is confined to hospitalized patients, and we're dependent on accurate diagnostic coding to reach the diagnosis both of PML and the underlying rheumatic diseases. And there wasn't any information available with regard to the therapy that these patients received. However, this is the bottom line here on the right-hand side, and after exclusion of more proximal causes for PML like HIV, cancer, or organ transplantation, the rate in lupus patients was 4 per 100,000, which was 10 times higher than that in the rheumatoid population, which was 0.4. So again, this supported the suggestion that lupus had a predisposition, but overall was fairly reassuring in that it seems that PML is a rare occurrence overall in patients with rheumatic disease. So given this, there appears to be this predisposition among lupus patients, what do we know about how lupus patients handle the JC virus? And unfortunately, not very much. This was a study of 20 lupus patients which didn't identify an increase in shedding of the virus in the urine or any change particularly with immunosuppressive therapy. None of the patients had JC viremia. And then this is a more recent study where they looked for JC virus DNA and the serum in the CSF of patients with neuropsychiatric lupus and controls, and didn't find it in any of these patients. So I think we're still a little unclear about what this predisposition would be. Clearly, patients with lupus do develop lymphopenia, but this is neither necessary nor sufficient for the development of PML, and clearly there are other factors at play. There have been a couple of other studies that have looked at the development of PML in patients with rheumatic diseases, and again, I suppose overall providing some additional reassurance that this is a relatively rare event. And this study did pick up a couple of the biologic cases, and this was a registry study from Sweden, which showed that there wasn't a non-significant but a slight trend toward a higher rate in RA patients compared to controls. But again, we're dealing with pretty small numbers in absolute terms. So what about biologic therapies then? So of course you've heard yesterday about the Natalizumab, and this binds to alpha-4 integrins, interferes with normal leukocyte trafficking, and had been in clinical trials for RA in addition to MS and Crohn's. When the initial reports came out of in clinical trials, which is obviously relatively unusual for what would normally be a rare event for this to be picked up in the setting of clinical trials. And you know where the story went from there, and you heard more about this from Dr. Fox yesterday. I suppose what's interesting about the Natalizumab story is that there a clear mechanism has been, or potential mechanism has been postulated on the basis of alpha-4 integrins being required for retention of pre-B cells and myeloid progenitors in the bone marrow, and therefore with its inhibition then there's an increase in hematologic precursors in the circulation, potentially losing control of JC virus replication. There's also decreased immune surveillance in the CNS and suppression of the trafficking of immune effectors to the CNS. So a number of potential mechanisms there. You've heard about the significant number of cases, and I think from Dr. Fox's presentation you learned that it was even higher in April of 2013, so you can see it's rising all the time. And with a lower mortality though than has been reported, typically for patients with non-HIV PML. And they now have strategies in place to mitigate the risk, and monitoring strategies in terms of MR. And in many cases now are picked up before the development of clinical symptoms, and these patients can have a very good outcome with apheresis. And they also have, again, facilitated by the significant number of cases, been able to look at ways to stratify the risk. And this is from a different publication than what you heard from Dr. Fox yesterday, but a similar sort of idea in that if you can stratify on the basis of the duration of Natalizumab treatment, JCV antibody status, and the history of prior immunosuppressive use. So at least Natalizumab has been able to weather this storm, and it is an important medication to have available for treating many patients with MS. Less fortunate was the fate of Natalizumab or Raptiva. This was another agent that impacted upon leukocyte trafficking, most specifically the CD11A component of LFA1, and this prevented T-cell egress. And this was FDA approved for moderate to severe plaque psoriasis. Worth pointing out that it wasn't in use for PSA. And about 46,000 patients had been treated worldwide from 2003 onward. In 2008, a black box warning with regard to a variety of serious infections had been issued. And not long thereafter, a number of cases of PML were reported, 4 cases in total, 3 of which were fatal. But it was striking because no prior cases had been reported in the setting of psoriasis. What's interesting in this month's New England Journal is that 2 cases of PML were reported in patients who were receiving fumaric acid for psoriasis. But this was a significant number in the setting of efanesoctocog therapy because it was very much in a somewhat similar fashion to natalizumab. It seemed to be time dependent, and this worked out about 1 out of 400 patients treated for over 3 years with this agent as monotherapy. So an advisory was issued by the FDA in 2009, and the company withdrew the agent shortly thereafter. So the other biologic agent that has received a lot of scrutiny with regard to PML is Rituximab, and this was on the basis of an FDA alert in 2006 of 2 patients with lupus who had been treated with Rituximab and developed PML, and they'd had other immunosuppressive therapies in the past, including cyclophosphamide, and both died of this PML infection. There was another alert then in 2008. This was the first rheumatoid patient, Rituxan-treated rheumatoid patient that developed PML. This patient had long-standing Sjogren's and had a number of other immunosuppressive therapies in the past, including a TNF antagonist, and was on methotrexate and some steroid also with Rituximab. And this patient had also been diagnosed with oropharyngeal cancer 9 months prior to the development of PML and had been treated with chemotherapy and radiation therapy for that diagnosis. So there have been, obviously Rituximab is used in other settings as well, and this is a report looking at from the RADAR database, which identified 57 cases of PML post-Rituximab. At that time, the vast majority in the setting of lymphoproliferative disease, and this did also pick up the 2 cases with SLE and 1 RA patient, and there were 2 other patients that had immune-mediated cytopenias that developed PML after Rituxan treatment. And this was a report that collated the first 5 cases in the setting of RA treated with Rituximab. So I suppose one of the questions in terms of a possible link with Rituximab is, well, what might that mechanism be? And it's less clear-cut than has been proposed for Natalizumab. Humoral immunity isn't protective in the setting of JC virus infection against the development of PML. It has been speculated that maybe loss of antigen-presenting function or cytokine production by B cells impacting upon T cell function might lead to a defect in cell-mediated immunity against the JC virus. Or could the release of pre-B cells with B cell repopulation after depletion with Rituximab potentially release cells that have latent JC virus infection, and if they're more immature, cells may be less well able to control viral replication, but this is an unknown at this point. Just to mention Mycophenolate, this was also the subject of interest from the FDA, and this was in 2008 when 10 definite cases and 7 possible PML cases with MMF were reported, including 4 non-renal transplant SLE patients. And then this was looked at in another study where they had a retrospective cohort of 32,000 renal transplant patients, and there was a lot of a lot higher rate, at least on paper, looking at PML versus in MMF-treated patients versus those not treated with MMF. But the problem was that there were very few patients not treated with MMF because it was sort of the go-to drug at that time for renal transplantation. So the results weren't statistically different between the two groups. But it still left us with a somewhat uncomfortable feeling of, well, what might the risk be in CellCept or mycophenolate treated patients in the setting of SLE, given that they felt that the lupus patients might be at risk. So we then went on to try and examine the association between PML and immunosuppressive therapies for autoimmune rheumatic diseases using the FDA ERS database, and this was through March 2010. We pulled out any cases that had an autoimmune rheumatic disease and confirmed PML as where there were characteristic changes in MR and detection of JC in the brain tissue or by PCR in the cerebrospinal fluid. And we looked at a number of other potential factors in the development of PML. So once again, we can see that of a total of 34 cases, lupus is overrepresented with 17 cases. In keeping with our previous results, we divided the patients into a biologic group, in which there were 15 patients, and then 19 patients in the synthetic-only group. These patients did not receive a biologic therapy. So then if we look at the breakdown of the immunosuppressive agents, we can see that in the biologic group, 14 of the 15 patients were treated with rituximab, and of those 14, all 14 were receiving rituximab at the time of development of PML. 6 patients had received anti-TNF therapy in that group, 5 obviously receiving rituximab after anti-TNF therapy. There was 1 patient who had ongoing anti-TNF therapy at the time of development of PML. As you might expect, the alkylators and this was mainly cyclophosphamide, were overrepresented, but the other agents are as you can see there. It's important to point out, I suppose, that a lot of the biologic treated group were also receiving other immunosuppressive therapies. So if we focus in on the rituximab patients, the median number of rituximab courses in these patients who developed PML was 2 with a range of 1 to 4. And the interval from the time of the first infusion to the development of PML was a median of 12 months, but again with a broad range. And then the interval since the last infusion was actually 5 months. So this would suggest that obviously freezing patients isn't going to help because the Rituxan has long come and gone. And it is also at least consistent with the hypothesis that the risk of PML might coincide with that repopulation of the peripheral B cells. So this is a slide which just tries to lay out some of the potential confounders for these cases of PML that developed in rituximab-treated patients. And you can see that there's a confounder for pretty much all of them except this case here, the first case. A number of them had lupus or lymphopenia or were receiving other immunosuppressive therapies. But you can see that there are 4 cases there that weren't receiving other immunosuppressive therapies at the time of developing PML. So in terms of the published literature, then we can say that there are the 5 RA cases and 2 lupus cases that we already heard about. Since the time of this report, there was another case of polymyositis reported, and this study then provides an additional 7 cases to the current study. I'm aware of one other case as a personal communication of an unpublished case, so that would give it a sum total of 16 cases of PML in patients treated with rituximab for autoimmune rheumatic diseases. With regard to anti-TNF, these were the confirmed PML cases from our study, and you can see that only one case, the bottom case here, was receiving ongoing anti-TNF therapy at the time of developing PML, and the remainder, apart from this case, which we didn't have as much information about, had received or subsequently received rituximab. And I suppose it's worth pointing out that this case at the bottom was a case of rheumatoid vasculitis, and this patient was receiving concomitant cyclophosphamide and infliximab and prednisolone at the time of developing PML. The median interval between the discontinuation of anti-TNF therapy and the development of PML was 3 years in these other patients. So what about the other biologic therapies? So there are no confirmed cases of PML associated with the use of other therapies for rheumatic disease, such as Natalizumab or abatacept, either in this study or in fact in the literature or upon questioning the relevant pharmaceutical companies. One case in this most recent study had exposure to anakinra 2 years prior to the onset of PML, but had been treated with a variety of other immunosuppressive therapies thereafter. This study is clearly limited by, again, reporting bias. This is a voluntary database. There's variable completeness of the reports, and once again, small numbers of PML cases. We're also unable to derive a true numerator or denominator for these cases. So what can we say about rituximab? It certainly seems to be a concerning signal emerging with discordance from our other therapies. However, it is certainly fitting with what would be defined as a very rare adverse event, less than 1 in 10,000, with the most recent figures available from the company suggesting that 209,000 patients have been treated with rituximab for the indication of rheumatoid arthritis, and there have been 6 cases in that setting, giving a total of a rate of about 3 per 100,000 for RA. What's less clear is the denominator for the other autoimmune rheumatic diseases, where we have 10 cases identified so far. So clearly ongoing vigilance is required. I would encourage any of you that encounter such a case to make sure to report it at least to the FDA or other regulatory authorities, if not also in the literature. There may be a heightened risk, obviously, in patients who have received alkylator therapy and possibly in lupus patients. We're still, I suppose, trying to identify what that mechanism of increased risk might be. With regard to anti-TNF therapy, there is a paucity of unconfounded confirmed cases in patients treated with anti-TNF with quite a significant denominator, possibly 3 million patients or so treated with these agents. And so there would appear to be little evidence of a clear-cut risk of PML. However, it's worth pointing out that there have been a couple of case reports with regard to anti-TNF therapy, not just in the setting of RA, but also for other indications. Many of the cases are confounded by other factors, but I think once again we need to keep this in mind when we see patients treated with these agents. With regard to mycophenolate, there were 6 cases in this study, but all 6 had previously received cyclophosphamide. 5 of the patients had SLE, so potentially other risk factors there. But MMF was the agent that was ongoing at the time of developing PML in 4 of the cases. It's probably fair to say, though, that there wasn't a clear signal above that seen with other non-biologic agents such as azathioprine and cyclophosphamide. So before we let abatacept off the hook, it's worthwhile pointing out that this agent, belatacept, which you've heard about earlier in the meeting, which is a recombinant soluble fusion protein, sort of the next generation of abatacept, directed against CTLA-4. This has been reported in association with 2 cases of PML in the transplant setting. So I think ongoing vigilance obviously required with abatacept also. So what can we really say with regard to all of this data? And I think that there's certainly a lack of clarity. But we can say that PML is a reported complication of a variety of autoimmune rheumatic diseases and synthetic and biologic immunosuppressive therapy. So we need to keep it in mind when evaluating our patients. So I'm just going to finish with a few quick practical points. Can I predict the risk of PML? How do I recognize it, and what can I do about it? Risk predictors, possibly SLE, obviously HIV and organ transplantation is a risk. Sustained lymphopenia, probably a risk. What about JCV antibody status? We've heard about that earlier in the meeting, but I think it's not quite ready for prime time outside of the setting of Natalizumab treated patients. There's been a recent report that suggested that there may be a false negative rate, and on the other hand, there's been some suggestion that maybe the titer rises at or prior to the development of PML. So I think we'll find out more about this, but at this point, given the significantly lower risk among our patients, it wouldn't appear to be a cost-effective strategy at this point. In terms of clinical suspicion, we need to think about PML in patients with unexplained progressive neurologic deficits with subacute onset, especially, but not exclusively, if they're worsening or not responsive to immunosuppressive therapy. A point of differentiation is that spinal cord or optic nerve involvement would argue strongly against a diagnosis of PML versus neuroinflammatory diseases. A normal MRI has a high negative predictive value, but the LP is typically fairly bland in terms of the routine analysis. Frank infarction is not a feature of PML, but contrast enhancement may occur and may confuse with some of our diseases. The JC virus PCR testing in the CSF is really the critical test, but there can be falsely negative, and you may need to repeat it or send it to a reference laboratory such as the NIH, where more sensitive techniques exist. A CNS biopsy is helpful in cases where the suspicion with regard to the diagnosis persists. And this is my last slide. In terms of the management approach, unfortunately, there aren't any great strategies, but it clearly would be important to try to maintain a high index of suspicion and facilitate an early diagnosis, and then promptly withdraw immunosuppressive therapy. Clearly, identifying and treating HIV is a potentially valuable strategy, but there is no proven drug therapy. The apheresis, which is useful in the setting of natalizumab therapy, is not applicable to other settings. So with that, thank you for your attention, and I'm happy to take any questions.